Hello again. We are trying to use this LMA Gastro device in prone position to do an ERCP. As you can see, this is the top end of the ERCP suit. We are ready with the LMA Gastro device, all the emergency intubation devices and everything, the catheter mount, the lubricating jelly. Placing the patient initially itself in prone position and induction in the same position after connecting all monitors. Induction about 3 to 4 milligram per kilogram of propofol. Depending on the patient's weight, we titrated a little less as well, some fentanyl, and then try to introduce the laryngeal mask array. The prone position poses some challenge in getting the neck position all right before insertion, but with some experience, it should come through easily. So the LMA is inserted in place. The catheter mount comes with the circuit connected well. The cuff is inflated to the green zone, and then the strap is placed to retain the LMA Gastro in place. The Teleflex has very intelligently designed this device, and if you can see there, the ETCO2 continuous tracing is seen, all vitals very stable. Dr. Khan, gastroenterologist, is ready to insert. One trick here is sometimes you may have resistance in passing it through if it is not lubricated well, as I said yesterday. You could also try and extend the neck a little bit, or keep a small sandbag under the chest to attain a good extension there on the neck so that the gastroscope passes in easily. So once it crosses the distal end of the LMA Gastro, it goes into the esophagus and then slips in very easily into the stomach. At the same time, you see a good tracing of the ETCO2. I'm changing over to my standard SMV mode, so that initially I ventilate them on this mode till they become fully spontaneous, so that my hands are free. And this is another view from the top end. The ERCP stent is about to go into place. They are more comfortable. They are absolutely, the procedure goes in very easily, and you don't need another assistant to hold the device in place. Normally we have a second person to hold the endotracheal tube if we have intubated the patient. But this device, the elastic strap, holds the LMA very well in place. No matter how much our pressure is exerted by the scopist, it stays in place without any dislodgement. So the worry of movement or dislodgement is absolutely very, very limited. And as you can see, it is placed well, and patient breathing spontaneously so well, and ETCO2 washout is absolutely good, and good tidal volume and adequate respiratory rate, and good MAC value of 0.9, and a low flow anesthesia, less than a liter of fresh gas flow, and wonderful vitals, good pulse oximetry values to satisfy you. That's the size of the stone, more than about 2 centimeter stone, and it has been stented well, and we are just about to complete the procedure and remove the scope. As I said, you don't need an assistant to hold it in place, and it comes off very easily. If at all you're worried, you can place a small index finger at the level of the plastic holder so that the device stays in place. And we are fine, the procedure is done. I'm cutting off the gases, the sevoflurane is turned off, and patient still spontaneous, very well, breathing all right. And I'm going to remove the LMA in the same position. The position, it doesn't vary, the patient stays in prone itself. Since they are breathing all right, patient fully awake, LMA comes off, they will remove it and give it to you. And no need for any major intervention, and patient placed lateral, and that's the happy result, as you can see there. So I'm quite happy using the device now, and I think with more gaining experience, we should do better. And I thank our hospital, GEM Hospital and Research Center, for providing all the support and facility to try and use such devices to help our patients go home much ahead and earlier than what it used to be earlier days. Thank you so much for your viewing.